So, special issues in treating ST elevation infarct in elderly patients and in females. So this is STEMI. I showed you a picture of stable coronary disease earlier. So here we've got our ruptured plaque. There's been platelet aggregation, activation, and thrombus formation. This is the same, whether the patient is young, whether the patient is old, whether the patient is a woman, or whether the patient is a man. Surely, therefore, treatment of STEMI should be exactly the same, regardless of how old you are, whether you're a man or a woman. These are the ESC guidelines on how we should manage ST elevation infarct. Probably can't see it at the top. It says reperfusion therapy is indicated in all patients, irrespective of whether you are male, female, old or young. Looks like this could be a very short talk. In an ideal world, what should we do in terms of reperfusion strategy in ST elevation infarct? Well, I think there's now no doubt that primary angioplasty is the preferred strategy. You get earlier arterial patency, more complete revascularization, smaller infarcts, better preserved left ventricular function, fewer complications, and improved mortality. And in fact, we've known that since 1993. So if you look here, the meta-analysis that we were just shown by Cindy Grimes is on the left-hand side, which suggested that primary angioplasty in clinical trials compared to fibrinolysis probably saves about 20 lives for every 1,000 patients that we do primary angioplasty for. Now, in the UK, we set up a project called the National Infarct Angioplasty Project, or NIAP, to see if primary angioplasty could be delivered safely and consistently across the whole of the UK. There was a pilot phase, and one of the centres was in London, and this is data on the right-hand side from London, showing in real-world practice the benefits of primary angioplasty. Probably saved about 78 lives per 1,000 at 30 days, and because of the reduced number of complications, even more lives at a year, 130 lives for every 1,000 patients in whom we did primary angioplasty. This is the situation in the UK. So PCI cath labs performing intervention are in blue, and as you can see, the situation in the UK, a very crowded island with lots of resources, is very different to how it is here. Angiography centres that don't do PCR are in red. So I work in Portsmouth, which is on the south coast. You can probably see it marked there. We are a 24/7 primary angioplasty service. We provide a population of about 1.2 million people with primary angioplasty 24 hours a day. However, in our patch, we, even in the UK, have areas in which it is very difficult to give 24/7 primary angioplasty. You may see there's a little island off the south coast of the UK, just off Portsmouth, called the Isle of Wight. There are ferries that run during the day. There are no ferries at night. We're very lucky we sometimes can get helicopters to fly, but sometimes we can't. And overnight, we still administer thrombolysis to patients on the Isle of Wight. We have a very similar setup to they have in New South Wales, where we immediately transfer patients who have had thrombolysis to an interventional centre with a view to either rescue angioplasty or a planned angiogram within 24 hours. But in an ideal world, there is no doubt at all. The best treatment for everybody with ST elevation infarct, if it's appropriate, is primary angioplasty. So why have we even been asked the question, what is different about the elderly and what is different about women? Well, thinking about elderly people with ST elevation myocardial infarction, what is different? Well, we know coronary disease gets increasingly prevalent as you get old, and we know, therefore, that this is data from the British Cardiac Interventional Society database that shows that whilst the majority of interventions in the UK are done in people in their 60s and 70s, we see lots of patients with coronary disease at a very advanced age. And the thing that concerns us as interventionists is that we know that elderly people are at higher risk from intervention. So this shows the increasing rates of death and myocardial infarction and stroke from, this is unselected intervention, increasing almost logarithmically as you get older. In addition, patients who are old often present differently. They present with atypical and often very mild symptoms. We know that patients who are elderly are at higher risk of bleeding, particularly with thrombolysis, where there are higher risks of intracranial hemorrhage, particularly also in people who have diminished renal function and comorbidities, which are increasingly common as you get old. As they present differently, it is very important to have a high index of suspicion for ST elevation infarcts in elderly patients, and it is very, very important to adjust doses of fibrinolytic, antiplatelet, and antithrombotic therapies appropriately in old people. These are the European guidelines, and it focuses on the elderly. It specifically says that we have to have a high index of suspicion in elderly people for STEMI. And again, it highlights the fact that we need to pay particular attention to the dosing of the medication that we give. So what actually happens in the UK if you're old and you have coronary disease? So the graph on the left-hand side shows the overall rates of percutaneous coronary intervention according to age. So the vast majority of people who have an intervention are under the age of 75, but 6% of interventions are performed in people over the age of 81. Now, I trained in Royal Bournemouth Hospital, which is another hospital on the south coast with a very elderly population. I know there are a couple of other people in the room who've trained there too. And in the Royal Bournemouth, 20% of the angioplasty that they perform is in the over 80s. This is specifically data looking at primary PCI. So you can see the Royal Bournemouth Hospital is the outlier above the 3 standard deviations from the mean, just above the red line, where over 20% of their primary angioplasties are performed in people over the age of 80. Now, we're not much better in Portsmouth, so we are the blue dot on the line just to the right of Bournemouth on the red line. So we do about 18% of our primary angioplasties in people over the age of 80. So it can be done. There are, however, some elderly people in whom primary angioplasty is not the right thing to do. Now, shock is an obvious example. This is data from the shock trial, and you can see the data for the people over the age of 75 on the right-hand side who clearly did worse with revascularization than with medical therapy. So if you are going to perform revascularization in elderly people, my preferred strategy would be primary PCI. I think it is safer than fibrinolysis if it can be provided. However, you can go too far. So, to sum up with the elderly, what would I recommend? Well, firstly, recognition in the elderly is key. They often present with those mild or atypical symptoms, and it is important to have a high index of suspicion. Age is no contraindication to drug, and that includes fibrinolysis or revascularization therapy. The oldest primary angioplasty that I've done was on a 97-year-old. Bleeding is probably our major concern in the elderly, particularly with intracranial hemorrhage with fibrinolytic therapy, but also at the time of primary angioplasty and with antiplatelet drugs. And it is extremely important to take things like low body weight, which is common in the elderly, and diminished renal function into account when you're dosing drugs. The other thing, comorbidities are increasingly common. And if the patient has got significant comorbidities with advanced dementia or cancer, primary angioplasty or fibrinolysis may well not be appropriate. Patient preference is also extremely important. So it is often interesting to have a chat with an 85-year-old coming in with an infarct. What would you like me to do? Usually they just say, get rid of my pain. And the best treatment for that is angioplasty if it can be performed. I do think you can go too far, and revascularization in elderly people who present with ST elevation who are already in cardiogenic shock is inappropriate and dangerous. So, moving on to female patients with ST elevation infarct. Well, what's different about female patients with ST elevation? It's important to remember that myocardial infarction is still a leading cause of death in women. It is the leading cause of death of women in the UK. And again, just like in elderly patients, it's more likely to present atypically. Women often present late. I suspect it's largely because they don't have wives to nag them to go up to the hospital. And they often present with atypical symptoms, just breathlessness or even just feeling generally unwell. Women, as we saw from the demographic graph that I showed earlier, tend to be about 5 to 10 years older when they present with cardiovascular disease, including ST elevation infarct. And when they're older, they tend to have more comorbidities. These are the ESC guidelines again, however, and what they recommend is that both men and women should be managed in a similar fashion, exactly the same. And again, they highlight that it's important to have a high clinical index of suspicion in women for ST elevation infarct. But there are differences in outcome between men and women presenting with ST elevation myocardial infarction. So if you look at the graph on the right here, this is men and women presenting with ST elevation myocardial infarction. And in this study, they showed nearly a doubling of in-hospital mortality in women presenting with an infarct. So what is different? What accounts for this worse outcome? So as you may remember from yesterday, platelets are one of my areas of specialist interest, and I did studies looking at response of platelets in women and men whilst on antiplatelet therapy, and there are definitely determinable differences between how men and women respond. So platelet aggregation in response to most platelet agonists is much higher in women, and women's platelets remain much more responsive after, for example, aspirin. There's also been strong associations shown between being a woman and having resistance to clopidogrel therapy. So could potentially some of these differences between men and women explain some of the difference in outcome when we look at myocardial infarction and ST elevation infarct? Well, I think the simple answer is no. So this is looking at differences in procedures, drugs, therapies administered for ST elevation myocardial infarction between men and women. Just to highlight here, so these are the odds ratio for whether you are likely to get a treatment. And what we can see is that women are less likely to be given aspirin, they're less likely to be given beta blockers, they're less likely to have an angiogram, they're less likely to have revascularization. Their daughter balloon times are longer if they do end up having primary angioplasty. And their deaths, again, in this study are higher. But the summary from this is that it is not differences between men and women in terms of response to platelets or anything that accounts for that difference in mortality. It is whether they get the right treatment. So in female patients, adjusted mortality rates, given that women on the whole are older when they present and have more comorbidities, are exactly the same if they receive the same treatments as men. So if they are given from fibrinolysis or primary PCI or aspirin or beta blockers, they do just as well as men. So for the female patient with ST elevation myocardial infarction, in summary, what do we need to do? Well, they are, again, undoubtedly higher risk. They are older when they present, they have more comorbidities, and they can present atypically. So the key is to recognize the fact that they are having an ST elevation myocardial infarction as early as possible, and then to treat them exactly the same. Again, women are at higher risk of bleeding, again, largely because they are more likely to have lower body weight, they're more likely to be elderly, and they're more likely to have renal impairment as they present later. Again, dose adjustment of all of their medication is key. At the moment, there is no doubt that in normal clinical practice, outcomes in women are significantly worse than men. But that is almost entirely due to our failure to give them the right treatments. So, to go back to the beginning, I said this could be a relatively short talk. All patients with ST elevation myocardial infarction should be treated the same. We should not be treating elderly patients or women any differently just because they are old or just because they are a woman. The one caveat I would put in is that we need to take extreme care with the doses of the medication, be it fibrinolysis, be it antithrombotics, or be it antiplatelets that we give to try and minimize bleeding risks. Thank you very much.